So this is a 42 years old male and who is not a known case of diabetes, hypertension. He's not even a smoker. He's a vegetarian guy and he don't have any addictions for the tobacco and nothing. So he presented with the CAD NSTEMI. This drop eye was 40,000 and on ECG there was a mild ST depression and LV function, mild LV dysfunction was there. So I can see how strange it is. There's no risk factors and all, and he presented with such a ACS, and you can see this is angio. This is a yellow caudal view, and you can see how bad thrombus is there in this LCX. This is a yellow caudal view, and this is a LCX. This is a LCX, and you can see there is a stenosis. There's almost 99% stenosis over there. And this is bad thrombus is there, and total cutoff of LCX is there, distal LCX. So this is a yellow caudal view, and this is a AP caudal view, and you can see the same thing, the stenosis, thrombotic stenosis over there in the distal LCX, and there is a Fent distal LCX. You can see this is RO caudal view. And this is a AP cranial view, and you can see the ectatic proximal LED and normal LED. And then again, if you see this RCA is normal, but you can see how ectatic and aneurysmal portions are there in this RCA. So everywhere there's a ectasia in LCX, in LED, in the RCA also. So it was decided to do the PTCA to LCX after all clearance. This seems to be a very easy case. Just put the wire and predilate and then stent it. But it is a distal LCX and you can see the angle between the LM and LCX. It is almost 90 degree. So crossing over there, and in distal LCX putting stent, that to a long stent we require. So it is not the easy case, it will be a complex case. This is a right radial route, and we engage the catheter. This is a XB catheter, and the thrombus was the organized thrombus, and you can see I made a knuckle. This is a BMW PTCA wire. I made a knuckle of the wire to cross it because we don't know, there may be a, you can see the proximal LCX is a aneurysmal. There's a ectasia, and in distal LCX it may be aneurysmal, so it can damage the wire induced perforation may be there, dissection may be there. So I was very carefully crossing the lesion with making knuckle. Knuckle is a wonderful technique for crossing in such a lesion, but that thrombus was so organized, it was not crossing at all. And then I took a support of the balloon, and this is a balloon support, and you can see the wire has gone into the false lumen, and luckily we noticed that the wire is in the false lumen, and it is a subintimal, and then we did not progress the balloon and we removed the balloon. So in orthogonal view also we checked whether the wire is in the true lumen or not. So it was not in the true lumen. I will show you in the further views that wire was out of the lumen, maybe a subintimal, and the patient was very stable. And meanwhile, I was not getting support with this XP catheter, so we had to change the catheter to the JL. It is strange that there was some sort of anomaly at the origin of the LM, and it was not getting engaged. It was not giving support while pushing the balloon. It was coming out of, and so I changed it to JL, and then I was getting support. So the second difficulty in this case was this wire was used to go in this OM. It has to go in LCX, but from here, because the OM was like this, it repeatedly used to go in this OM. So that was again the problem. That was after changing the wire. I changed the wire, and then this is the again loop, because I thought it was in the subintimal space. So again I made a loop, and then I was trying to push this loop with the torquer in the wire. If you see now, again the wire is in the subintimal, and again we had to remove the wire and all. In all orthogonal view I checked and it was not in the lumen, you can see here. So in this view clearly you can see wire, where is the wire and where is the LCX. So wire may be in some small branch or anything, but here what you can see is there was a big dissection here. There was a big dissection here. It may be while passing the wire and passing the balloon that time. Then we removed the wire and then we we tried to progress the wire in the true lumen, and then somehow after some time we progress the wire in true lumen. And the second problem is we require large more than 40 millimeter stent, but it was not possible because there was an acute angle in the L6 and LM. So while passing the stent it was not possible, so we took a 2 stent of 24. This is an epicranial view, and you can see this is the first stent we placed at the distal part of the distal LCX, and this was the second stent in the proximal part of a distal LCX. It was again, the distal stent was 2.75, it is 3, and deployed at almost nominal pressure. And this is a cine after deploying 2 stent. You can see how the LCX has opened up. There is a ectatic segment in the proximal LCX. There was some haziness in the just at the ostium of the OM, but it is not significant. And so this was the cranial view, and you can see how large the LCX has opened up after this angioplasty. So this was the angioplasty to the difficult distal LCX with 90-degree angle with LAD with LM, and there was many difficulties in the crossing. There was a dissection and there was a tortuosity. So distal L6 is not the easy angioplasty, that too the thrombus loaded LCX. And finally there was a TIMI3 flow and patient is stable. While when there was a dissection, patient was very stable. Just there wasn't any perforation and all. Probably the wire went subintimal, and then we covered with stent. So this was the difficult angioplasty to the LCX. Patient is stable.